we're going to go ahead and get started. Welcome to the House Standing Committee on Health Services, meeting number 4. I am pleased to see everyone here, and we've got a pretty full agenda, so I think we will go ahead and have DJ take the roll.
Representative Bentley. Here. Representative Bratcher.
Here.
Representative Bray.
Here.
Representative Burke.
Here.
Representative Callaway.
Present.
Representative Dotson.
Here.
Representative Duvall.
Here.
Representative Fraser Gordon.
Here.
Representative Justice.
Here.
Representative Neighbors.
Here.
Representative Rayburn.
Here.
Representative Raymer.
Here.
Representative Riley. Representative Rorks.
Here.
Representative Sharp.
Present.
Representative Swan.
Here.
Representative Weber.
Here.
Representative Wilner. Representative Whitten.
Here.
And Chair Mosier.
I am here. Okay, we have a quorum established to do business, and so we'll just go ahead and get started. The first bill we will hear is House Joint Resolution 38. We have with us Representative Boffman. If you could please make your way to the table and introduce yourself for the record, and as well as your guest, and please proceed.
Thank you, Chair Moser. My name is Representative Jared Ballman, House District 28.
And Madam Chair, I'm Ken Fleming. I represent the 48th District, which is a part of Jefferson and Oldham counties.
So thank you, Chair, and to the committee for hearing House Joint Resolution 38 today. This resolution came about from an EMS task force and is really asking the Cabinet for Health and Family Services to evaluate the reimbursement rate for emergency medical services and then take the appropriate action to increase those rates where possible, when possible, based on what they learned through that evaluation. And also to submit a state Medicaid plan amendment to cover treatment in place without transportation for emergency ambulance services. And Representative Fleming can offer some more detailed information about the task force. I was not a part of that, but I'd be happy to entertain any questions that you guys have.
He did a fabulous job.
Okay, we have a motion on the bill, and do we have a second? Second. Okay, do we have any further comments or maybe an explanation of the rationale for this? I just think it's interesting.
Thank you, Madam Chair, for the question. With House Bill 777, that this body approved, as well as in the Senate and in action, basically out of that we found a lot of issues and challenges when it comes to EMS infrastructure, from workforce to reimbursement rates to training to you name it. It came to service, and it was a very long process, but it was very rewarding. And this is one of the items that came out of this, is that many of these, actually these EMS workers have not been reimbursed for over 10 years. And so there needs to be a thorough study to figure out what is going on in terms of how to compensate these individuals when they go and treat somebody. Sometimes if they don't go to a hospital, they don't get paid. There are some situations where they will get paid, but for the most part, that's more a minority amount of the time. So based on that and based on other things we came across, we really thought this was a good idea from the EMS task force last year to come up with this type of a process to get the cabinet to look at this reimbursement schedules. And there's a lot of other things that's coming through the House also that sort of came out of the EMS task force.
Okay, thank you so much. We have one question.
Thank you, Chair. I had a constituent reach out to me recently, a situation where her daughter needed to be transported, but it wasn't to a hospital. It was for behavioral health services. Would this resolution, identify solutions that would enable someone to go directly to behavioral health services as opposed to a hospital?
Representative, this resolution will not address that, but your point is well taken, and I appreciate you bringing that up because that's exactly the thing we came across in terms of transporting mental health patients, because sometimes there's a liability issue with that. And so what we're looking at doing is we've worked with K-Beams and other, I guess, over 12 other associations to look at what are the alternatives. And like Lexington and Fayette County have some alternatives to transport these individuals. And I'll just use don't take this verbatim, but an Uber-like type of a process that if they're endangering themselves and so forth, then they can look at alternative to transport that individual to get get the services that they need. But I appreciate the question.
Okay. See no further questions. DJ, please take the roll.
Representative Bentley. Representative Bratcher.
Yes.
Representative Bray.
Yes.
Representative Burke.
Yes.
Representative Callaway.
Yes.
Representative Dotson.
Yes.
Representative Duval.
Yes.
Representative Frazier Gordon.
Yes.
Representative Justice.
Yes.
Representative Neighbors.
Yes.
Representative Rayburn.
Yes.
Representative Raymer.
Yes.
Representative Riley. Representative Rourke.
Yes.
Representative Sharp.
Aye.
Representative Swan.
Yes.
Representative Weber.
Yes.
Representative Wilner. Representative Whitten.
Yes.
Chair Mosier.
Yes. Okay. All right. House Joint Resolution 38 passes with favorable consideration, and the same should pass on the floor. Congratulations.
Thank you, Chair.
Thank you. Okay, next we will hear House Bill 56. If Representative Bentley could make his way to the table, and any guests, please introduce yourself for the record and just go ahead and proceed.
I'm Joe Dan Beavers, represent Life Skills in Bowling Green, Kentucky.
Eric Embry representing the Pennyroyal Center in Hopkinsville, Kentucky.
Steve Shannon with CARP Association of 12 of 14 Community Mental Health Centers.
And I'm Representative Dan Bentley, District 98. Thank you, Chair Lady, for hearing this bill in committee. The Community Mental Health Centers, known as CMHCs, were established by the Federal Community Mental Health Act, which was the last piece of legislation signed by President John F. Kennedy. Kentucky was the first state to implement the federal legalization establishing CMHCs as the behavioral health public safety net provided in the Kentucky Revised Statute 210. The legislation establishing the CMHCs, passed in 1964, created a regional model established to assure that behavioral health safety net services would be available in all 120 counties, and to designate the particular CMHC which would be responsible in each county for assuring that the services were delivered as required. The CMHCs as a behavioral health public policy net are required to respond to community needs, including involuntary psychiatric hospitalizations, as we know, 202A, involuntary admissions, review nursing home admissions to some individuals, crisis response to community partners in the community during natural disasters, such as the tornadoes in western Kentucky and the flooding in eastern Kentucky. KRS 210-485 outlines the governance, the responsibilities, and duties of the CMHCs. There are 14 statutes included in KRS 210, and the word regional is used a total of 13 times. In addition, the heading on the LRC website for KRS 210 is Regional Community Mental Health Program. It should be noted that KRS 210.370 through 485 does not list the regions and the counties within each region. It should be noted that the contracts issued to each CMHC by the Department of Behavioral Development and Intellectual Disabilities, that we know as DBHDID, include the names of each county within that CMHC region. As you see in the slide here, it shows you the regions. Also, the CMHC Medicaid Manual, incorporated by reference in Medicaid regulation, clearly states a community mental health center, CMHC, shall provide a comprehensive range of accessibility and coordinated mental health services, including direct or indirect mental health services, to the population of a designated regional service area as required by KRS 210, the Community Mental Health Center Behavioral Health Services Manual. The CMHC licensure regulation, 902 KAR 20, includes a community mental health center. A, it shall provide a comprehensive range and accessibility and coordinated behavioral health, mental health, and substance abuse services, and services for individuals with an intellectual or developmental disability, including direct or indirect services to the population of a designated regional service area, as required by KRS 210. In addition, other quasi-governmental entities have their respective regions clearly defined in statute or regulation. Area Development Districts, KRS 17A. Child Advocacy Centers, 922 KAR. Domestic Violence Shelters, KRS 209A. Rape Crisis Centers, 922 KAR 8. In conclusion, based on the Kentucky Revised Statutes, CMHC licensure regulation, DBHDID contract language, and the Kentucky Medicaid conditions of participation, the CMHC model is a regional model. House Bill 56 confirms the CMHCs as a regional model. On your screen here is the difference between a CMHC and a BHSO. HB 56 does not prohibit a CMHC from providing services and supports in counties outside its designated region. The Cabinet of Health and Family Services may issue a license to the CMHC to be operating as a behavioral health service organization. BHSOs are similar to CMHCs. Help me here. My finger. Yeah. I had a little surgery, couldn't get that together. BHSOs are similar to CMHCs but do not have a designated service area. Again, a CMHC license as a BHSO can provide services in any county outside of its designated region. HB 56 simply lists in statute the counties included in each of the regions served and supported by the local CMHC. HB, in conclusion, 56 affirms there is only one behavioral health public safety net provided in each region, responsible for the full range of services in the region, and that the CHMC designated of that region. The Committee on Health and Family Services supports this bill and parts of the licensing. Thank you, Chair Lady.
Okay, thank you. Any comment from the other gentleman at the table? Okay. So I have a quick question. You covered this more or less, but what we're trying to do is maintain coverage for any unmet need outside of a designated community health center region. And the BHSO licensure will allow individuals who are operating as a CMHC to go outside their region to provide that care. Okay.
Correct.
Okay. I just wanted that clarification.
Yes.
Okay. Yeah, thank you. Do we have any questions from the committee? Okay. Do we have anyone speaking in opposition? Oh, well, you know what? Hang on just a second, too. We do have a committee sub that we need to adopt.
Yes.
Okay. So we have a motion on the sub. A second. All in favor of adopting the sub?
Aye.
Any opposed? Okay. So are there any questions? Okay, but we have a motion on the bill. Do we have a second? Okay. All right. Is there anyone here to speak against the bill? I think we're good. Okay. All right. DJ, please take the roll.
Representative Bentley,
Aye.
Representative Bratcher,
Yes.
Representative Bray, Representative Burke,
Yes.
Representative Callaway,
Yes.
Representative Dotson,
Yes.
Representative Duval,
Yes.
Representative Frazier Gordon,
Yes.
Representative Justice,
No.
Representative Neighbors,
Yes.
Representative Rayburn,
No.
Representative Raymer,
Yes.
Representative Riley, Representative Rourks,
Yes.
Representative Sharp,
Yes.
Representative Swan,
Pass.
Representative Weber,
Yes.
Representative Wilner, Representative Witten, Chair Mosier.
Yes. And we do have some members who are back and forth between state government and here, so we may have others who register votes, but House Bill 56 passes with favorable expression, 15 to 2, 1 pass, and the same should pass on the House.
Thank you, Chair
Thank
Lay.
you.
Thank you, gentlemen.
Okay. Next, we will be taking up House Bill 200. We'll go a little out of order. Representative Fleming, if you could come to the table, and please invite any guests that you have with you to the table, and please introduce yourselves for the record and proceed. We do have a committee sub on this bill. We have a motion on the sub. We have a second. All in favor of adopting the sub? Any opposed? Okay. Please proceed and speak on the committee sub.
Thank you, Madam Chair. I'm Ken Fleming. I represent the 48th District, which is parts of Oldham and Jefferson County. And I'll let my guests introduce themselves, and I'll start from your far left.
My name is Todd Lyles. I'm Senior Vice President of LHC Group Louisville.
Is your microphone on?
Sorry. My name is Todd Lyles. I'm Senior Vice President of LHC Group in Louisville, Kentucky.
Good morning, Madam Chair and Committee. Aaron Thompson, President of the Kentucky Council on Post-Secondary Education.
Good afternoon. My name is Betsy Johnson. I'm the president of the Kentucky Association of Healthcare Facilities. We represent skilled nursing facilities, personal care, and assisted living communities.
Madam Chair, did you want me to explain the House Committee sub first? Sure. So basically, there are two main changes in the House Committee sub. First one was inherently omission of social workers, which is in your first section. So that's been included in there. The other one, I think it was in section 2.7. No, section 2 and number 7, and basically it deals with having the General Assembly, particularly two committees, Health and Family Services and Education, to review and work with the CPE in terms of regulations and making sure these goals are accomplished in terms of what we're setting out to do. So that's basically two changes that this Health Committee addresses. Okay. I want to first of all thank my guests up here because we've worked really diligently in terms of trying to get something really innovative to address what I think the two main challenges we have in this Commonwealth: education workforce and then healthcare workforce. And this is a very innovative process in order to do that. I do want to highlight one person that who took my calls at 10 o'clock at night and texts in the morning at 7 a.m., and that's Miss Leslie Sizemore. She's been instrumental not only in class but also in intellect, and I just want to basically highlight her and thank her very much for all her patience in going through this process. Ladies and gentlemen, this committee, this is a really innovative, creative approach. Basically, it's a public and private partnership that takes dollars and matches dollar for dollar of private funds. They'll go into a healthcare workforce investment fund. There's two buckets that the money will go into. The first bucket is for scholarships. over 65% of the money is going to be allocated for those scholarships. The other bucket is going to be up to 35% that will help in terms of providing support in bringing on faculty, as well as those assets or equipments that the faculty needs to help provide training in order for these individuals to get certification and then as well as a license. There is really strong language in there that we want to make sure that we get a return on our investment. So there's a lot of accountability that's going to be coming back to the administration, into the General Assembly, and making sure that our dollars are getting toward what we're trying to achieve, and that is looking at not only the healthcare, occupations and individuals throughout the state, but also look at those underserved areas in the Commonwealth. CPE, who's going to be coordinating and overseeing this, has been instrumental and very helpful in getting this, in help shaping this legislation. They're going through and look at where those deficiencies or those needs are in those underserved areas, not only in the occupation or healthcare worker, but also regionally. For example, I know a representative asked a question a few minutes ago about EMS and so forth. There is a significant need and deficiency in the eastern part of the state when it comes to EMS workers and so forth. So that was going to help quantify that. There's been over 12 associations have been involved with this, that they're supporting this piece of legislation. And I'm going to go ahead and have Dr. Thompson sort of make some comments and give a little more information about the bill.
Thank you, Representative. Madam Chair, there's several things I could say about this and not take up too much air in the room. I'll just say a few things that are clear based on my 20-something years in healthcare as well as education. This is a very innovative bill. You know the dire need for all kinds of healthcare workers now. Well, we also look at predictive analytics and see that it's going to grow. And if you look at prescriptive ways of handling this, I cannot think of a better legislative process than this. This public-private partnership creates on the front end and not the back end. In other words, front end, you got employers working with their campuses, developing what's needed for today, as well as 5 and 10 years down the road. You have an assessment process that ensures you have what is going toward quality as well as quantity, and be able to know that you are getting a return on investment. It's an equitable process. It looks regionally, it looks within also each of those elements as we concentrate on where I'm from, Clay County, Kentucky, as well as from inner city Louisville. It concentrates heavily on all those areas that I would argue that in the past we've always been behind the 8 ball on. We know we're probably never going to catch up with all the needs that we have. But I'll give you an example from last year when the legislature appropriated $10 million for us to build out what I call a beta example. And we did this with a collaborative, healthcare workforce collaborative. We have, with that $10 million, we have 49 partners putting a lot more skin in the game, and we're producing. Our numbers quickly are showing that this offers a sustainability effort that goes way beyond just what we've seen with this one-time beta that we did last year. Last couple of things I will say is that it is important for us to think about this in a manner of how we start developing the ways we do other business with this public-private partnership, how we think about doing a variety of what I consider to be innovative higher education. So fully support this bill. I really appreciate Representative Fleming for working with us to make sure we not only got an innovative bill, but one that will work and one that can be applied in a system that will cost us less overhead dollars to make happen.
Go ahead, Todd.
Sure. My name is Todd Lyles, and I work for LHC. Our company is a home health company that provides services nationally, providing home health, hospice, and personal care services. In Kentucky, we have 52 offices serving 2/3 of the state. And in our office, we see the number one problem today is staffing. We just can't find enough staffing. We did a study a few months ago that said nationally we would be willing to hire 4,000 healthcare workers across the country and we could hire over 350 in Kentucky alone. And this is something that we've tried to solve on our own. We've raised wages. We've paid bonuses for stay on, sign on, whatever we can do to try to attract workers, and we simply can't find them. So we need a solution, and it's a solution that we're willing to participate in. This is a public-private partnership, and we think government, by providing the opportunity for scholarships, we're willing to put up our money to match some of those scholarship funds, to provide training sites for the students, and ultimately to provide job locations for them. So we fully support Representative Fleming in this bill and look forward to its passage.
Thank you, Representative Moser, for hearing this bill, and members of the committee, and appreciate Representative Fleming's leadership on this. Our story is similar to home health. I think this committee is painfully aware of our workforce shortages in long-term care. Nationally, over 210,000 positions were lost in long-term care alone since the COVID-19 pandemic. In Kentucky, that represents a negative 14% change in nursing facility employment. We surveyed our membership, and 88% of our members who responded to our survey reported some level of staffing shortage. 75% said it was difficult to very difficult to hire new staff, and there are over 700 open state-registered nurse aide positions within our member facilities. That's 700 open state-registered nurse aide positions within our member facilities. Nurse aides are the backbone of long-term care, so we greatly appreciate Representative Fleming including nurse aides in House Bill 200, because we also firmly believe that the more nurse aides we have, the stronger our nursing pipeline will be in Kentucky. So I do appreciate Representative Fleming and Representative Mosers and members of this committee. Thank you.
And Madam Chair, I'll just conclude by saying that this basically what it simply does, it's this bill kickstarts career paths for all Kentuckians interested in healthcare career, and it puts a jetpack on the healthcare training pipeline. So I thank you very much. Be more happy to entertain any questions.
Okay. We have a motion on the bill and a second. I just have a quick comment. I'm very, very pleased to see this project moving along. I think that leveraging private dollars, and especially from those who will directly benefit in the increase in healthcare workers, is a very smart way to proceed. I love P3s. I like creating partnerships, so I appreciate all of your work on this. We are keenly aware of the healthcare worker shortage in Kentucky, and I know last year we passed an expansion of the loan forgiveness program, and this is a little bit different, targeting a different population of healthcare worker, and I agree that this increases the pipeline, the potential pipeline for those healthcare workers. So thank you very much for all of your work. Appreciate it. We do have a couple of questions. Representative Bray. Oh, Representative Bentley.
Thank you, Chair Lady. Dr. Aaron Thompson, are protocols and agreements with physicians necessary for this to work?
No, it's not necessary, but it would be desired, is the way I see it. I mean, because what you have here is within a hospital or ambulatory setting, outpatient, all of those, physicians are a key element to this conversation, right? But and they fully buy into it, because much of this focuses on what really makes those settings work beyond what physicians do. And so they're very much, and even me being with Baptist, I can tell you our physicians are excited about this sort of action. It's not required that is in place, but it is desired for them to do it, and I don't think we'll see a problem of them not wanting to do it.
Thank you.
Okay. Do we have any further questions from the committee? All right. Seeing none, we have a motion and a second. So, DJ, if you could please take the roll.
Representative Bentley?
Yes.
Representative Bratcher?
Yes.
Representative Bray?
Yes.
Representative Burke?
Yes.
Representative Callaway?
Yes.
Representative Dotson?
Yes.
Representative Duvall?
Yes.
Representative Frazier Gordon?
Yes.
Representative Justice?
Yes.
Representative Neighbors,
Yes.
Representative Rayburn,
Pass.
Representative Raymer,
Yes.
Representative Riley, Representative Rourks,
Yes.
Representative Sharp,
Aye.
Representative Swan,
Yes.
Representative Weber,
Yes.
Representative Wilner,
Yes.
Representative Whidden, and Chair Moser.
Yes. Okay. Oh, Representative Wilner.
Thank you, Madam Chair. I'd just like to record yes votes on House Joint Resolution 38 and House Bill 56.
Thank you.
Thank you.
Okay. Okay, so House Bill 200 passes with favorable expression, 18 yes votes, 1 pass, and the same should pass on the House floor.
Thank you, Madam Chair. Thank you, committee.
Congratulations. Thank you for your work.
Thank you.
Okay. Next, we're going to hear House Bill 290, and I'd like to invite Representative Steve Bratcher to come and explain the bill. If you have any guests, invite them to the table now and introduce yourself for the record and proceed when you're ready.
Good morning, Madam Chair and the committee. So my name is Steve Bratcher, Representative Steve Bratcher, and I've got the OIG here for helping talk a little bit about this bill. So I got Adam Mather.
Yep. Adam Mather, Inspector General for the Cabinet.
Kara Daniel, Deputy Inspector General.
And I'm Sarah Cooper, Legislative Director for the Cabinet.
We should have everybody here that should be able to explain this lengthy bill. Okay, so this is basically a Casper cleanup bill, and there's about 4 criteria to it. One is that Casper can be used to exchange with other partners in federal programs, so across state lines. And then the other one is there's an exception that's in there for nonprofits. So if there's a nonprofit health clinic that's prescribing medication, they're exempt from having to use the Casper system. And then there's some language that clarifies the requirement for a practitioner or pharmacist who's authorized to prescribe or dispense controlled substances, and they must have an active Casper account. I think before there was some confusion about that. There was 2 different accounts. You have to go on and get one account, and then you have to get the actual Casper account. And I think this outlines clears up some confusion that it is a Casper account you have to have. And then there's some minor changes other changes that were deleted out the out-of-date language.
Yeah, sure.
Chime in.
The last one is obviously hydrocodone, drugs with hydrocodone in them moved from a Schedule 3 to a Schedule 2. So we just cleaned that language up.
Okay, thank you. All right, we have a motion on the bill. We have a second. All right, do we have any questions from our committee members? Dr. Bentley. Please turn your microphone on.
Turned it off. That first federal, could you explain that a little better?
Sure. So we have, unfortunately, as it currently stands, we're unable to share with the hospitals on military bases, the VA clinics and hospitals, and so this will allow us to participate with those federal partners.
Well, I understand that, yeah, okay. Because I knew we had every state with Casper because we included Missouri as the last one. Also, do you think a Casper could be used to report under vital statistics the death of opioid deaths in the future?
I would have to get back with our, with our Casper team, but we're working on the modernization project will be finalized, and so that's probably something we could put in one of the phases.
One more
yes,
comment.
sir.
When a person dies of an opioid overdose, that information, if it's not reported, would not get back to our executive officers, like a sheriff department. they need some way of getting that information back. So that's the reason I was asking it, since you're from Casper.
Sure.
Thank
Yeah,
you.
yeah. Appreciate it.
Of course. All right. We'll see no further questions. I'll have DJ go ahead and take the roll.
Representative Bentley. Yes. Representative Bratcher.
Yes.
Representative Bray. Representative Burke.
Yes.
Representative Callaway.
Yes.
Representative Dotson.
Yes.
Representative Duval.
Yes.
Representative Frazier Gordon. Representative Justice.
Yes.
Representative Neighbors.
Yes.
Representative Rayburn.
Yes.
Representative Raymer.
Yes.
Representative Riley. Representative Rorks.
Yes.
Representative Sharp.
Aye.
Representative Swan.
Yes.
Representative Weber.
Yes.
Representative Wilner.
Yes.
Representative Whitten.
Yes.
Chair Mosier.
Yes. Okay. House Bill 290 passes with favorable expression unanimously, 20-0. Nicely done. Congratulations. The same should pass on the House. Thank you. Okay, next we are going to take up House Bill 134. Hang on, Representative Whitten, did you want to register some votes?
Yes, but I'm not sure.
Okay, well, no, we're not. All right, so would you like to register votes now, since?
Yes, I'd like to register a yes on House Bill 56. And House Bill 200, yes.
Okay, thank you. All right. Okay, I will make my way to the table and invite my guest to the table while I hand over the gavel to my co-chair, Representative Dotson.
House Bill 134. Representative Moser, you may begin.
Thank you. Thank you, Mr. Chair. Thank you, committee members, for listening today to this important legislation. I am Representative Kim Mosier. I represent the 64th District, and I'll allow my guest to introduce herself.
Hello, my name is Dr. Mona Lisa Taylor. I'm a board-certified internal medicine physician and the current president of the Kentucky Medical Association.
Thank you. Thank you for being here. And we do have a committee sub, which we'll need to adopt.
We have a motion on the sub. All in favor say aye. Aye. All who oppose? Committee sub is adopted.
Okay, thank you. So today we're talking about prior authorization, which is a process that health insurance providers employ to determine medical necessity for coverage of a test, treatment, or procedure. It's a time-intensive process by which a physician must submit their rationale for prescribing a certain test or treatment to get permission from the insurance company to provide the care that they know that their patients need. Healthcare providers spend years training to determine the best course of treatment for their patients. Prior authorization delays care by often days or longer. It's an expensive and time-consuming layer of bureaucracy to healthcare. Both doctors' offices and insurers have full-time staff just to deal with obtaining prior authorization or utilization reviews and to get these approvals. And these expenses ultimately get passed along to all of us as patients. So I would just like to relay a quick story, and I know Dr. Taylor has stories of her own being in private practice, but 2 days ago I had a constituent join me in my office who described his situation as a hemophiliac. He started seeing spots in his left eye. It was determined that he needed emergency surgery for a detached retina. He arrived at the hospital for this emergency procedure with his medications that he takes every day for his hemophilia and wasn't allowed to bring medications from home, so they needed a separate prescription in the hospital, which took 3 days to obtain approval for, delaying his surgery. His surgery was successful, but there was a good chance that he could have had serious outcomes. He could have been blind. And so the delay in obtaining the prior authorization has clear health outcomes, and they're not usually positive. You're going to hear that the federal government has begun work to fix this problem as well, which highlights really the overall problem. If the feds are talking about this, clearly it's a problem. But part of what they say in their comments and their opinion in this proposal is that they encourage states to go ahead with their plans to deal with prior authorization and all of these types of exemptions for providers. So they're actually encouraging states to go ahead with their plans to do this. I also have a letter from CMS. We asked the question about, what is it that you are encouraging states to do? What sorts of comments would you like? And what we received back was it was in regard to the question. We asked for comments for consideration for future rulemaking and asked whether or how gold carding or this exemption for prior authorization exemption programs could reduce provider and payer burden and improve services to others. So clearly this is a recognized situation. It says also that the proposed rule will not have any effect on states' gold carding programs. So I just wanted to mention that while I was thinking about it. So obviously CMS recognizes this as a burden. So what House Bill 134 will do, it will allow insurers to evaluate a healthcare provider's experience with obtaining prior authorizations over the previous 6-month period. It will provide an exemption then to those providers from prior authorization if they have demonstrated an approval of 90% or better of their applications for prior authorizations over that past 6-month period. This will eliminate the need for healthcare providers and their staff to spend hours on the phone or behind a computer trying to obtain permission to treat their patient with the care that they know they need, taking time away from patient care. The exemption, if it's awarded, will continue until it's rescinded by a health insurer. And what we've allowed in this language is an audit twice a year of all of the, well, not all, but between 5 and 20 cases to provide a snapshot of that provider's prescribing habits and to make sure that that the prescriptions are falling within medical necessity. We don't want this to get out of hand. We have worked with the insurance plans to tighten up some of the language. There actually one provision that the committee sub added was to say that if a physician is part of a review process, we had that they had to be the similar or the same specialty. We know that that's not always possible, and so we said when possible. So Again, this will ensure that healthcare providers who are providing medically necessary care will have this burden lifted, saving healthcare costs, and will ensure that patients have no delay in their care. This is one more step in creating efficiencies and addressing the high cost of healthcare and health provider burnout. Kentuckians shouldn't have to worry if they'll have access to the treatments and medications that were prescribed by their doctor.
We do have a motion on the bill.
Oh, we have a motion on the
Got
bill.
a motion, but we do have some folk here speaking in opposition to the bill, so we want to give them an opportunity.
Mhm.
Okay, to speak. Yeah, we also have a doctor on Zoom that wants to speak as well. Okay. So before we take any motion for the bill, we will have them come up. Is there any final comments?
If I could allow Dr. Taylor to make a few comments, I
Sure.
would appreciate that.
Sure.
Thank you.
Thank you, Representative Moser and Chairman. I appreciate the time. Just wanted to share a few comments from the Kentucky Medical Association survey that we conducted earlier in the fall with some comments from physicians across the state. And just want you to be aware, 82% of physicians in our survey said that there were a lot of issues with prior authorization, delaying to their patients' care, and changing their course of treatment for their patients. 7 out of 10 physicians said that the amount of work related to the prior authorization process has increased over the last few years. They also stated that 81% of the prior authorizations delayed the access to care for all these patients, and some of the examples that they provided I found very interesting. They stated that delay in care often adds to the time my patients are in pain because diagnostic and therapeutic procedures are being delayed. Several times each week, I have to change my treatment plan from what I consider to be optimal because of these denials. Elimination of this unnecessary burden would help me see more patients. The other stories that were shared were a good example of what impact this has on our patients who are losing quality of life and having delays in their time with their family and missing work. So some of the examples that they shared was, one was really difficult. It was that a patient drowned due to a low blood sugar while they were waiting for a prior authorization on a continuous glucose monitor that would have told them that their blood glucose was low. Another story that was shared was that an oncology patient needed a nausea medication, and that medication required a prior authorization. In the 3 days that they were waiting for this prior authorization to come in, the patient got admitted to the hospital with nausea, vomiting, dehydration, kidney failure, and electrolyte abnormalities. This is something that is definitely impacting our patients, and making an impact on prior authorization would help our patients lead better lives and help them maintain their course of treatment.
Thank you, Dr. Taylor. Thank you,
Thank you.
Representative Moser. Anyone on the committee have any questions or comments? Representative Bray.
Thank you, Mr. Chairman. Let me start out with saying, love the bill, hate prior authorization, think it's the dumbest thing. Personally had a wrist injury, needed to see an orthopedic doctor. Had to have an x-ray done. No reason why. The doctor knew that the x-ray wasn't going to show anything. It's a tissue injury. They tell me, hey, got to have this x-ray done anyway. Insurance won't approve it. So go to have the x-ray done. Knowing good and well, I've got to have that to see the orthopedic guy. And so then, got to have a CT scan done. Can't have the CT scan done until I see the orthopedic guy. So meanwhile, instead of just getting the CT scan in the first place because my doctor knows that that's what I need, I've got to jump through all these hoops. And that's driving up the cost of my health care. It's a pain in my hind end, and it's an issue. But then, at the same time, I'm looking at the mandate statement that dropped within the past couple days. The mandate statement is $0 to $12 per member per month. How are we supposed to make a decision on anything that could be from $0 to $465 million? Do you have any insight, or do you all have any idea what this, and maybe the insurance companies would be better suited to answer this, but do you have any idea on your end, like what this would actually cost?
So I appreciate that question very much because I wanted to touch on this. Yeah, this just actually dropped this morning. So, and it's something that we have requested. It's been in the works for a while. So in the statement, it says that the Department of Insurance Analysis included use of data and statistics from the Kaiser Family Foundation, America's Health Insurance Plans, Texas Association of Health Plans, and an actuarial judgment. You see that all of the data came from the health insurance plans. We don't have any input from healthcare providers or any entities who hire entire departments of folks to work on this. So I don't believe that we're going to see anything on the high end. In fact, I think it'll be closer to the zero and the neutral position because we have data from DMS that who relaxed these regs around prior authorization for behavioral health and substance use disorders during COVID. And when we looked at the data, the utilization went up as we would have expected because it was during COVID and it was for behavioral health, but the cost per member per month actually went down. So, we have a snapshot from DMS that says, despite the utilization increase, the cost actually went down. I would say that if we get to a neutral position on this, that the cost, I believe it'll be offset by, the patients won't have any delay in their care. They won't have those additional health care costs. We're going to see this time-consuming and expensive burden be lifted from not only our providers, but from the health insurers themselves. They have entire industries who do nothing but utilization review, and that's who you're going to hear from. I think Evacor is here, and that's all they do. So if we have businesses built around this, clearly this is a money-making venture for those entities, or they wouldn't be in business. So I guess the other thing that I'd like to mention is that researchers estimate that waste in healthcare, including the administrative costs like prior authorization, amounts to $245 billion per year, or $2,497 per person in the U.S. So I think that we have this wide range, this huge range of potential expenses, and I think the question is, or the answer may be, that we don't really know. But if we see snapshots of data and these cost estimates of waste, which prior authorization, it creates some guidelines and guardrails. We want to make sure that all of the prescriptions and the treatments that are prescribed by a physician are medically necessary. And we've put provisions in the bill that allow for fraud detection. So I'll stop there. I mean, but thank you.
You answered the question because, in my mind, if I'm not having to take 3 tests just to see a doctor and to get where we know this is going to go, I can't, but the 0 to 46.5, I don't understand that.
Right.
And then you mentioned the waste, and I realize, this isn't the time to talk about health insurance liability and all of that, but my goodness, we prescribe so many unneeded tests, and this does get headed in the right direction. So I do appreciate it. Thank you all.
Yeah, thank you. And I think, the overall goal of this is to stop delays in patient care, get the cost down, and trust physicians to make the best decisions, not some bureaucrats. So thank you.
Representative Wilner.
Thank you, Mr. Chairman, and thank you, Chair Moser, for this bill, and Dr. Taylor for being here. This is so important. We know the health statistics here in Kentucky, and this is just removing another really unnecessary barrier to patients receiving the help that they need. So I appreciate this, and I want to thank you for the sub for including the behavioral health providers, because we talk a lot about subscribers and MDs, physicians, but we know also that we're in a mental health crisis in our state, and that these prior authorizations get in the way of psychological assessments, of a number of behavioral health treatments for substance use disorder, for all kinds of mental health crises. So I really just wanted to thank you and to emphasize the mental health piece of this as well. So
Thank you.
Thank you. Representative Bentley?
Thank you, Chairman. PAs have taken half my life away and made me white-headed.
All of them are coming up.
So if you know why I'm white-headed, it's because I stood with the phone like this so many years. And 2 weeks ago, I had carpal tunnel syndrome from holding that phone waiting on a PA. So PAs, when you get them sometimes, I've had patients come in, documented, that a trade name wouldn't cause them a rash, and a generic would, where their face swelled out where you wouldn't recognize that patient and not be able to PA to a trade name to save that person misery. And I've had PAs change antipsychotic drugs where that person wants to commit suicide.
Yeah.
So I'm white-headed because of PAs. Thank you.
So the one comment I would like to make, so these audits that are done twice a year, is that correct? That will prevent any fraud if they go in and see that they're working within the parameters of care given. So there's some safeguards there to make sure a physician is prescribing or doing adequate care. So I really like that provision of the bill. So
Thank you.
gives us confidence there. Now, going forward, we do have a motion and a second on the bill, but before we take the vote, we do have some opposition that we're going to give an opportunity to come to the testimony desk. So, Representative Mosier, if you'll hang tight for just a moment. And I have several that's coming to the desk, and I would just like to ask each of you to make it brief. We've got to get out on the House floor here shortly, but please give us your testimony. We've got Scott Brinkman, Tom Stevens, Hope McLaughlin, Matthew Noss, and Eric Graudes.
Thank you, Chairman Dotson. I think we'd like to begin with the testimony of Dr. Gravis, who's with you telephonically and through the video. By the way, my name's Tom Stevens. I'm the president of the Kentucky Association of Health Plans.
Good afternoon. Am I coming through okay on audio? Okay,
Yes.
wonderful. So thank you, Chair Moser. Thank you.
We need you to introduce yourself for the record.
I apologize. My name is Dr. Eric Gracious. I am a board-certified pediatric oncologist, and I'm the Chief Medical Officer for Evercore Healthcare. And we do medical benefit management in all 50 states, including Kentucky. And I'm here to talk about, maybe to correct some of the misperceptions that I hear in the testimony that's come before and some of the comments and questions. And I have no doubt that some of the stories we heard happened, and they make me sad and they make me cringe because they're not what this process is designed to do. The truth is that this conversation is a lot more complicated than the initial presentations might lead you to suspect. Prior authorization began decades ago as a mechanism to control, spending around very high cost services, which for the time wouldn't even register today. You would never even think about them today. And, over time, it has evolved into quite a different model. The people that are doing this work well, and they're doing this work in a modernized fashion, are focused on improving patient quality. And it's really about applying evidence-based medicine accurately. As a matter of fact, I even heard in the comments from the Medical Association, one of the physicians even admitting that the care plan changed after the conversation because of a conversation around evidence-based medicine. That's actually good for that patient, because what's happening is medical evidence is continuing to evolve at an ever-increasing rate. And there's a published study back in 2011 that looked at the doubling time of medicine over a period of years, and I will keep it brief. But using the rate of rise over 3 different time points and modeling that forward to 2020, medical knowledge was doubling every 73 days. So gold carding in itself is based on a flawed premise. It's based on the premise that any physician anywhere, no matter how good they are, no matter how hard they try, can keep up with the changes in evidence-based medicine. And blind spots creep into your knowledge that you're unaware of. That's why they're blind spots. And the effective prior authorization serves to fill those knowledge gaps for the benefit of patients. And I hear stories about delays in care, again, like the ones that were shared that make me cringe, but I think we also need to understand that prior authorization removes delays in care when patients are going down the wrong path. One of the things that happens during a prior authorization, as evidenced by our Kentucky Medical Association colleagues, is that sometimes care is it's redirected, it's not stopped. And that is not done based on cost, that's based on adherence to evidence. And sometimes that redirection, the evidence says you're doing something more costly. We'll use the imaging results, the imaging example provided earlier. We very commonly will look at a request, and I've done this myself, where a request has come in for a CT scan of the head of a young child with a new headache. And the evidence is really, really clear. The best study for that patient is an MRI. A young child with a new headache is always a reason to get advanced imaging. But you're wasting time and letting the patient get sicker by playing around with x-rays and CTs. And so by redirecting to that MRI, we're saving weeks sometimes in that patient's care. So it's more complicated than prior authorization causes delays. Sometimes physicians cause delays. Well-intentioned, but they're delays. So this is really focused on the patient. And then when you focus on the gold carding itself, the impact here is not, I'm going to challenge the assessment on the zero. That is just not what we have seen. Gold carding is not a new concept. It's been tried in the past. And what happens is almost any physician, if you tell them, here's the mark you've got to get to either achieve this goal you're looking for or to avoid this consequence you don't like, you can do it for a short period of time. But once the oversight is gone, behavior will regress. And so that's just natural human behavior. So it's really about how do you have the right controls in place. And looking at 20 cases over a 6-month period, for when you're making hundreds of decisions a day, it's really a tiny sample size. So it's not very effective. And when you think about the threshold for a minute, this is a conversation that's come up in multiple states. And as a physician, I tend to see it sounds good on paper. You hear 90%, you're like, that's a good score. That's an A on my algebra test. Every physician in the room got over 90% their whole life to get into medical school, to get through medical school, to do everything else. But when we were talking about this in another state, I had a representative say, I've heard, I saw this bill and I'll save you your breath because I hate this bill. I said, I was a little shocked. I said, okay, tell me why. And she said, well, it sounds to me like the Medical Association is telling me that I need to pass a law that says physicians can mess up 10% of their decisions and I don't get to care about that. And that was really quite shocking for me, but it was very telling to how this sounds to the average person who just wants health. They just want to get better. They want to have optimized health and move forward. And when you take that a step further, a 10% error rate, I mean, in patient care, find me a clinic, find me a hospital, find me a nursing home, find me anybody that thinks even a 2% error rate in patient care decision-making is safe or good or acceptable. So there's some good stuff in this bill that that are good starting points to help to reform prior auth, to tackle some of these administrative burdens. But gold carding does that at the expense of patient safety. And it is quite dramatically cost additive to the system. Because what we have seen is even with this incredibly low bar of 90%, very few physicians actually qualify for any exemptions. And there is a tremendous amount of net new infrastructure that has to be built by the state, by the practices, by the health plans, just to manage who has a gold card and for what service and when. And then the rescinding on the back end. So the net impact on the administrative burden is to increase it further. So there's things we can do, and we would love to partner in helping to reform prior authorization. This just isn't the way. And I want to give the other folks at the table a chance to speak, and I'm happy to stay around for questions. So thank you so much for your time, and thank you especially for allowing me to participate remotely, as due to some emergency I wasn't able to travel today.
Thank you, Dr. Gracious. And those of you sitting at the desk, if you would, just state your name for the record and proceed.
I'm Tom Stevens. I'm the president of the Kentucky Association of Health Plans.
Matthew Nash, I'm the Director of Government Affairs for Evercore Healthcare.
Scott Brinkman, representing the Kentucky Association of Health Plans.
Rusty Cress with Dinsmore and Show on behalf of America's Health Insurance Plans.
And I'm Hope McLaughlin with Anthem Blue Cross and Blue Shield.
And I guess I'm up next on this one. This is somewhat the easy part. I get to say we haven't seen the committee sub, so we don't know exactly what we're speaking to, but I will get a copy and do what's necessary to analyze that. My chore is to bring to your attention the fact that we do have federal rules in the process. It's my understanding that the public comment period ends in March of this year to deal with prior authorization issues. And those federal rules are going to deal with response time frames for PAs, much more detailed analyses of the reasons for denials, an electronic process for requests and decisions, and annual reporting mechanisms to really keep an eye on it. So I think that the effective date of those regulations were going to be sometime in the 2025, 2026 range. And off script just a tad, but I would like to take a personal note on this. I was hospitalized 4 times last June for some very serious health issues. And I was terrified when the doctor told me that one of my surgeries was going to change. And I thought, okay, great. Well, I was on the table, and I was a little concerned about how long prior authorization was going to take. Well, it took 5 minutes for my insurance company to say, yes, we think that that's an appropriate way. So I do not question that there are horror stories, but there are also success stories. And it worked out pretty good. Sorry for you all.
Thank you, Mr. Chair. Appreciate that. I'm just going to identify a few points. First of all, we appreciate the opportunity. We've been working with Chairwoman Mosier on this for really over a year now. Also with representatives of the Kentucky Medical Association, and most recently, we did provide written comments to the bill. We haven't seen the committee sub, but we'd be happy to share that with staff, members of the committee, so that that can be shared as well, so that we can help refine this. We aren't opposed to prior authorization. It's a major issue, but we are opposed to the bill. So having said that, I just want to hit on a few highlights. As members of this committee are aware, Kentucky has a significant number of people that are in Medicaid. Right now, that number is in the area of 38% of citizens of the Commonwealth as a result of expansion during the public health emergency. 55% of the members of Medicaid, or 55% of Kentucky's children, are in Medicaid today. And one of the elements that's unique about this bill versus any of the bills we're aware of anyplace else in the United States right now where gold carding has been implemented, particularly Texas, which is the only state that's really done something along these lines, is that this bill would include Medicaid. It would also include CHIP. That is not in any of the other bills. So I take note of this because Texas has had a really difficult time implementing this bill. It's sort of a Swiss cheese combination of different things with lots of holes in it. As a result of that, what was supposed to be a relatively quick implementation is just an IT turnaround, in fact, was a 15-month process. They've only just activated their gold carding program exclusively for commercial insurance in October. We really don't have any data back yet. I'm in regular communication with Texas trying to get information on it. But when you think about what we're proposing to do in Kentucky is not just commercial insurance, but also Medicaid and CHIP. That is a much bigger lift. And the deadline for implementation of this bill is, or at least was before the committee sub, I haven't seen that, was January 1 of 2024. And that's just, it's not a realistic expectation. I would say if you were strictly looking, and I would defer to Dr. Gracious, but if you were looking at exclusively commercial coverage, 18 months would be a reasonable time frame. Next thing that I'd like to add there also, House Bill 134 does have restrictions, particularly in Section 5, on health plans' ability to recoup inappropriately paid funds through the Medicaid program. So we're concerned about that. We think it's probable that that would lead to litigation pretty quickly. And we also have concerns about self-funded plans, which you're probably aware under ERISA. Those are preempted. They are also not covered by this bill. So you're also going to have dual operation of systems internally where somebody could walk in, for example, could be a third-party administrator program that Anthem runs. They're also going to have an Anthem card. And so it's going to be another situation. We're going to have more administrative abrasion related to this on behalf of the patient. And I think I'll pass it on if there aren't any specific questions now. I was going to let Scott go ahead and speak unless you, thanks.
Yes, I just want to make one point, and that is Chairwoman Moser correctly points out that the federal rules, and there's actually 3 federal rules that were published in December of last year. The federal rules do not prohibit the states from proceeding with prior authorization legislation. But the reality is your health plans are only going to have one PA system. They're not going to have a state system and a federal system. And to go forward and require our plans to start to implement House Bill 134, knowing that the federal rules are out there for comment now with effective dates of January 1, 2026, strikes me as requiring our health plans to incur administrative expense that really is not necessary because, yes, states can have their own laws, but under the Supremacy Clause of the United States Constitution, the rules published by CMS will have precedence over any state laws or regulations. And I also point out that there's 2 parties to the system, that whatever systems, and Dr. Gracious pointed this out, whatever systems that the plans come up with to comply with House Bill 134 and or the federal rules, the providers are going to have the same systems. They're going to have the APIs that speak to each other. So there is going to be a significant administrative burden placed on both counterparties to these transactions. And again, I want to make the point that we know the federal rules are been published, that the federal government is keenly interested in basically preempting the states in this area. Does it make sense at this point in time, knowing these federal rules have been published in the last 2 months, to require our Kentucky health plans to start to implement very complicated, very expensive system configurations to comply with House Bill 134, knowing that ultimately they're going to have to do the same thing to comply with the federal rules, and the federal rules do take priority under anything that the state does. Thank you, Mr. Chair, members of the committee.
We need to wrap this up pretty quick, so no
Sure.
great pressure, but just want to let you know.
I will be quick. So again, Hope McLaughlin with Anthem Blue Cross Blue Shield. First of all, I want to say that Anthem supports efforts to streamline prior authorization and is continuously modernizing, improving, and when appropriate, removing PA requirements for certain services. Anthem has developed a number of innovative programs that reduce prior authorization burden for qualifying providers that are in value-based contracts and have a proven track record of following evidence-based medicine. One of those programs we started in 2018, Prior Auth Pass, and it's expanded to Kentucky and allows providers to waive PA for a number of outpatient CPT codes. Anthem is also engaged in developing new technology aimed at reducing prior authorization turnaround times and overall burden. For example, Anthem developed an AI-powered tool that researches an electronic medical record for medical necessity terms, and if those terms are found, can recommend approval of the prior authorization request. Another example is Anthem's work with Health Level 7's Da Vinci project, which is in the process of finalizing data standards for a prior authorization application program interface, or API, that providers can link to. As others mentioned, CMS is working on implementing a series of 3 major rules over the next 3 years that will change prior authorization across the country. Implementing a program of the scale outlined in House Bill 134 will likely prove to be difficult as carriers and providers work to implement these new rules. CMS has advised that states should align their rules with CMS. Healthcare is a complex and volatile business. For this committee and the Commonwealth to act on this now would be premature with the work ongoing at the federal level, and will serve only to increase the challenges and complexity within the system. We, Anthem, and the industry have proposed multiple reasonable options to the sponsor and advocacy groups that would allow the General Assembly to take some action on gold carding in a way that would require insurers to make meaningful advancements in the area, but not be a barrier as we await the federal rules to be finalized. Advocates might say that the pending rules encourage gold carding programs. That's true, I agree with that. But these rules encourage carriers, not states, to take action on this at this time. With this in mind, we ask you to vote no on House Bill 134 in its current form, and we remain open to working with the KMA and the sponsor on this important issue. Thank you.
Thank you so much. I do have a couple, I'm sorry, do you?
If you don't mind, Mr. Chair. I'd just like to I want to piggyback off what Dr. Gracious said, just 30 seconds of your time, if you don't mind. So Dr. Gracious mentioned in his statement that medical knowledge is moving extremely fast, right? So he cited the University of Iowa
Real quickly, would you
study.
state your name for the record?
Matthew Ness, Director of Evercore Healthcare, that medical knowledge changes or doubles every 73 days. So I just want to put some stats very quickly behind that change. So just in 2019 alone, the National Comprehensive Cancer Network, NCCN, which is a not-for-profit leading cancer center, just in 2019 alone, issued 170 guideline updates across 54 cancer types and 18 new oncology drugs. This is highlighted by a recent study by a group called Doximity, which is the largest physician network in the United States. About 80% of doctors are part of this network. And when they were polled together, 2/3 of physicians report feeling overwhelmed by the amount of information they have to keep up with all these new changes. So I just wanted to throw that. And just finally, one more thing. We have to also remember, first and foremost, prior authorization is a patient safety tool. But we also need to come to the realization that there's an incredible amount of wasteful health care, some of which was mentioned in this testimony. But I'll just cite a Journal of the American Medical Association 2019 article that said wasteful healthcare spending is estimated to be as high as $935 billion with a B dollars on an annual basis. That's 25% of total healthcare spending. So I just wanted to put those stats out and provide a little bit more information from what Dr. Gracious. Thank you very much for your time, Mr. Chair.
Thank you, ladies and gentlemen. We do have a couple of questions on the panel here. Representative Bray?
Sure. So I'll ask a question along those same lines as earlier. 0 to 1233 per member per month, 0 to 465 million for fully insured policies, and that's not taking into consideration Medicaid. What are we looking at from your all's perspective? I mean, obviously, I would be personally a lot more concerned with the 1233 than the 0 number. But from your perspective, in other states that they've done this, what's the actual number we'd be looking at?
You want me to start?
Well, one thing I want to point out is that there is no other state aside from Texas that has implemented a program of this scale. There are some other states that have implemented programs or passed legislation like Louisiana that has mandated that insurers adopt prior authorization programs themselves. Totally open to having that conversation. Anthem especially, and I'm sure other health plans as well, have prior authorization programs, gold carding programs in place. In terms of the cost, it is hard to get a good estimate on this because this is a new process, and you also don't know how many. We can make estimates, but we don't know how many physicians are actually going to hit that 90% threshold on everything, so that's something to consider. One thing that I would point out regarding the cost estimates, health mandate statements are a wonderful tool for the legislature. In addition to that, fiscal notes are as well. It's concerning that this bill applies to both Medicaid and to the Kentucky Employees Health Plan, and there's no fiscal note attached to it. And so I think that, as the bill moves forward in the process, I think that would be an important piece of information for the legislature to have in front of it before they made a decision on this legislation. Tom, did you have anything to add?
And then just one follow-up. I guess it's more of a statement. The prior authorization process as a patient is extremely frustrating. From the hospital perspective, it's extremely frustrating. From the pharmacist perspective, it's apparently frustrating. So whatever recommendations you all have, can you please give those to us so that we can do a better job and get rid of these stupid things? Thank you.
Thank you, Representative Bray.
Thank you. Representative Bratcher?
Yes, thank you, Chair. This is for the Dr. Gracious. What standards do you use when you're determining whether a service or medication should be approved? I mean, is there is there a guideline or a standard who gets approved and who does it in the time frame?
Certainly. Thank you for the question. So I will speak for our approach, and we represent a large number of health plans, including many in Tennessee. But I think my colleague from Anthem would agree that their process is very similar. Our guidelines are based on the evolving scientific evidence. So they're specific to patients' conditions, and they're an accumulation of the medical knowledge that is coming, whether that's coming from an organized body like the American College of Radiology or the National Comprehensive Cancer Network, or it's an accumulation of evidence from a variety of different sources and published in one format. Those evidence-based guidelines are publicly available on our website as it is for most health plans. They're shared freely, and those clinical standards are the basis upon which that medical necessity review is performed. The people doing those, and I do want to challenge the mischaracterization that was shared earlier about the quality of the people doing this work. And I neglected that in my opening comments. The people that we employ are experienced clinicians, all of whom have multiple years of real-world active clinical practice in their specialty. If they're a physician, is a nurse, a genetic counselor, a physical therapist, and it is those people who are taking the clinical information that is provided, whether that's in writing or by phone, and applying the evidence to that and determining how does the patient's care align with that. Approval decisions are often extremely fast. The overwhelming majority of our decisions happen in under 1 day. The ones that take a little longer are the times where we need to exchange information. The patient is more complicated. There may be information that wasn't shared, but these are all expert people who would maintain active state licensure, active board certification, active continuing medical education, and have significant experience managing the patient's condition. These are not unqualified people. These are not bureaucrats. These are clinicians. They're experienced professionals who are focused intensely on making sure patients get the right care. Thank you.
Thank you. Just one more comment. I think your numbers might be a little bit off. You said $935 billion was your cost, but there's a 1.9 million is what the people that are card carriers for Anthem. If you multiply that times 12, which is what Representative O'Hare mentioned, then it'd be 24 million. It wouldn't be 935 billion. So I don't know what you were referring to on that. And then I also noticed on Anthem that I wasn't concerned with that number, since Anthem looks like you all doubled profits last year to 1.1 billion. So I wasn't concerned with the numbers that the representative was giving me. Thank you.
I have a quick question. Tom, you may have answered it and I may have just missed it. But the question is, have any states implemented prior authorization exemption and then withdrawn the law?
I don't have an answer for that, Representative Dotson. I'm sorry. But we can certainly research that and look at it. I bet, Matt, do you have a...
Was the question around if the rule was implemented and then it was withdrawn? Was that,
yes.
To my knowledge, no. There were about 13 states that, last legislative session that tried to implement or brought forward, introduced legislation around gold carding. They varied a little bit. None of them passed, and I think once these lawmakers understood the impacts, they ultimately did not pass into law.
All right. Thank you all very much. This time I have Representative Mosier to come back to the testimony table. And we already have a motion by Representative Callaway and a second by Representative Bray on the bill. DJ, you do the roll call.
Representative Bentley.
I want to explain my vote. This is very confusing. Some points that are talked about evidence-based medicine and medical knowledge changing so quickly. You know, I went down and see where they made the Coast Guard cutters, and they don't put IT in them to the last 3 days because it changes so quickly. However, we see this scientific evidence changing so quickly. In Kentucky, we don't have rural health. We need people to help in rural health, and we need people to OK PAs so we can get people taken care of. There's people out there trying to destroy protocols on pharmacy. We got people dying if they do that. We got to stay with evidence-based, take care of the people in rural Kentucky, okay some PAs, or they're going to die on us. I've been there. I've been 50 years behind the counter. So I vote yes, but I do have these concerns, and I think it needs to be refined a little bit. And then on the 10%, we maybe need to refine that a little bit, Representative, because a lot of us work on 0%. I worked 50 years, and that's the reason I'm white-headed, but I think you're giving them too much leadway there. Thank you.
Representative Bratcher,
Yes.
Representative Bray,
Explain my vote, please. I'm a yes. Like I said, I mean, anything we can do to move the direction of eliminating needless, useless, stupid tests, whether it's for prior authorization or whether it's for medical malpractice liability, whatever the need may be, I'm for it. It is a little concerning that we've got a impact statement that is so wide, but there are good things that we can do. So I vote yes.
Representative Burke,
I'd also like to explain my vote. I'll be voting yes. I do share concerns both about the 90% threshold and also about the forthcoming regulations, or recommendations from the federal level. And finally, without a fiscal note and our decreasing budget, I am concerned whether or not the state of Kentucky can absorb the increased possible costs that may come along from expanding this at a statewide level for people on the KEHP and Medicaid.
Representative Callaway,
I have a yes with reservations, if I could explain. So I would like to see some actual numbers. Anthem mentioned removing, they have been actively working to remove some of the PA. I'd like to see which ones they're talking about. I'd just like to see some activity. And I would also like to work towards how can we incentivize carriers to move in that direction versus more legislation. If we could just some kind of incentivizing option. And I too expressed the 90%, though I was assured that that number is usually really a lot higher, but hearing the conflicting testimony here today, I'd like to see some kind of numbers to back up one way or the other. But yes.
Representative Dotson,
Yes.
Representative Duval,
Yes.
Representative Frazier Gordon,
Yes.
Representative Justice, Representative Neighbors,
Yes.
Representative Rayburn,
I'd like to explain my vote, please. I'm a no for today. I'd like to see the physical impact statement for the Medicaid and state employees. I think that's a major concern. This topic is very, very important. I've worked in healthcare for many years. I've done a lot of PAs in my time, and they are a hassle. I don't have white hair like another representative, but they're a hassle, and I've seen a lot of patients that have been hospitalized because a PA wasn't approved timely. So, but I think we've got some more work to do. So I'm a no for today. Thank you.
Representative Raymer,
Yes.
Representative Riley, Representative Rourks,
Explain my vote. So I do have concerns about the uniformity across states, however, have greater concerns over the health impacts to waiting on such legislation, and so I'll be a yes today.
Representative Sharp,
Aye.
Representative Swan,
Yes, with some reservations.
Representative Weber,
Yes.
Representative Wilner,
Explain my yes vote. I'm a yes on the bill, and I do just want to express my solidarity with the frustration about not being able to see committee subs in a timely way. That's hard on committee members as well, and I know it's hard on members of the public. So that's not aimed at this committee in particular, but it's been a problem. But yes on this good bill. Thank you.
Representative Whidden,
Yes.
Chair Mosier,
Yes.
House Bill 134, as amended by the committee sub, has passed favorably. 18 yeses, 1 nay, and the same shall pass on the House floor. Thank you.
Thank you. And I don't normally do this, but if I could just address some of the comments about the Medicaid cost. I cited one example. I should have said during testimony that we have asked DMS for all of those numbers, and we weren't able to get those. So I'll keep working on that. But for the snapshot in time for those 2 years during COVID, when the regs were relaxed, it showed a decrease in cost. So, I mean, you know, that's real life example. And then just the last thing, and there are other things we could talk about, but the 90% and 10%, that's for prior authorization. That is not an error rate. So that 10% was misconstrued as an error rate. Now, I know that most physicians and other healthcare providers who prescribe treatments often have a 99% rate. I mean, it's very common, and a lot of times that 10% is, it's not approved the first time, and it's approved on appeal, so that counts as a non-approval. So, and just the last thing is, I am absolutely willing to work with the insurers on this. I know that there is a lot that we can do. The federal government is working on interoperability and streamlining these services, and we don't want to interfere with anything that they're working on. So yeah, if we can work on an infrastructure that jumpstarts this process and just lifts some of this burden, that's what we're looking to do. So I really appreciate everyone's support. Thank you.
Thank you, Representative Mosier. Can I get a motion for adjournment? We are adjourned.